All right, welcome back. Today, we're going to get really granular on a skill that is absolutely fundamental to everything we do in knee arthroscopy, portal placement. It's the first move we make, and frankly, getting that opening move right determines how the rest of the procedure is going to play out. So let's really dive in.
So, let's start with a tough question, and be honest with yourself. Is your portal placement technique a deliberate, optimized strategy for each specific case, or has it kind of become muscle memory, a routine you just fall into? It's so easy to just get in, but are we truly thinking about the best possible entry for the pathology we're about to tackle? It's a good thing to challenge ourselves on.
Because really, everything flows from that initial entry point. Your ability to see what you need to see, how your instruments triangulate, your efficiency, even your ability to avoid damaging healthy cartilage, it all comes back to where you made those first 2 or 3 incisions. So yeah, mastering the entry point really is the first step to mastering the whole procedure.
Okay, so before we even think about a scalpel, let's talk setup. This is where success begins. Section 1 is all about positioning for success and how we can set the stage to give ourselves every advantage possible right from the get-go.
We basically got 3 main options for positioning. There's the classic supine with a leg holder, which is great because you can use your own body as a post to apply valgus stress and really open up that medial compartment. Table flat is, well, it's table flat. And then you have the dangling leg technique where you drop the end of the table. This is fantastic for relaxing the femoral nerve, especially if you anticipate a longer case. Each one is a strategic choice, not just a default setting.
And here's a small detail that makes a big difference. Don't forget the other leg. Wrapping the uninvolved extremity is such a simple step, but it's critical for minimizing the risk of venous stasis. It's one of those little things that shows you're thinking about the whole patient, not just the knee you're working on.
So, the age-old question, to inflate or not to inflate? Well, it really depends on what you're trying to achieve. If you're heading into a complex meniscal repair or a trauma case, you absolutely want that bloodless field and inflated tourniquet gives you. But, and this is a big but, for a diagnostic scope, I'd argue for keeping it down. Why? Because you can see the true vascularity of the tissues. You can assess the healing potential of a meniscus in a way that's completely impossible once everything's blanched out.
All right, now we're getting to what I think is the most important principle of all. You have to draw your map before the landscape changes. Because the second that joint fills with fluid, all your reliable bony landmarks get fuzzy and much harder to palpate.
This quote right here, this should be your mantra. It is absolutely non-negotiable. I'm telling you, taking those 30 seconds to carefully mark the knee before you turn the fluid on will save you minutes of frustration, and more importantly, it's your #1 defense against iatrogenic cartilage scuffing. It's probably the single best habit you can build for consistent, flawless portals.
So what does that map actually look like? Well, pretty much exactly like this. You want to feel for and outline the patella, trace the patella tendon, and then, while flexing and extending the knee, palpate and draw your medial and lateral joint lines. Don't forget the posterior curves of the femoral condyles either. This blueprint becomes your unerring guide.
Okay, our patient is positioned, the map is drawn. Now we're ready for our guided tour of the standard portals. And I want you to think of these not just as holes, but as 4 unique windows, each giving you a very specific view and a specific job to do.
We'll start with the undisputed workhorse, the anterolateral portal. This is your eye in the sky, your primary viewing portal. If you place it correctly, about 1 centimeter up from the joint line and 1 centimeter lateral to the tendon, you get this amazing panoramic view. But you've got to know its blind spots. It has a really hard time seeing around the corner to the PCL and the far back of the medial meniscus.
And where you place this portal vertically is a game of millimeters, but with huge consequences. If you go too high, it feels great at first. You're above the fat pad, it's easy to move. But the problem is the femoral condyle will completely block your view of the posterior horns, and that's where so much of the pathology lives. Go too low, and you're fighting through the fat pad. And worse, you risk spearing the anterior horn of the lateral meniscus. It's all about finding that perfect sweet spot.
Over on the other side, you've got the anteromedial portal. This is your working portal, the path for all your instruments. It's basically a mirror image of the anterolateral. Now here's the most important technique I can give you for this. Never, ever create this portal blind. Always start with a spinal needle. Put your camera in the anterolateral portal, and then watch on the screen as you slide that spinal needle in. Confirm its trajectory, make sure it's perfect, then you make your incision. It's the best way to prevent damage inside the joint.
Now to get to that tricky posteromedial corner, you need a dedicated portal.
There's a sequence to doing this safely. First, you need to really distend the joint to balloon out that posterior compartment. Then flex the knee to 90 degrees. This relaxes the neurovascular structures and tenses the capsule, letting you feel that little soft spot. Using your pre-drawn joint line as a guide, you can enter safely about a centimeter above it. This portal is an absolute game changer for posterior horn tears.
And finally, let's look up front at the patellofemoral joint. For that, your best friend is the superolateral portal. This gives you the perfect vantage point to watch the patella track as you flex and extend the knee. And if you're dealing with a symptomatic medial plica that needs to be resected, this is absolutely the portal of choice.
So, those 4 standard portals, they'll get you through probably 90% of your cases. But for that other 10%, when you're facing down some really tough posterior pathology or difficult anatomy, you need a few more tools in your toolkit. So let's look at some optional portals for those special situations.
Right, the posterolateral portal. This is essential for accessing the back of the lateral compartment, but you have got to respect the anatomy here. We're talking about the common peroneal nerve. The absolute key to safety is flexing the knee to 90 degrees. This lets the nerve drop posteriorly and gives you a much safer window. Your entry point is just anterior to the biceps femoris tendon, right at the joint line you marked earlier. Next, the proximal mid-patellar portals are great for when your instruments feel crowded up front. They can give you a much better angle of attack. And finally, the central transpatellar portal. Honestly, reserve this for ACLs and only go through the tendon after you've harvested your graft. You just want to avoid injuring that tendon in a routine case.
Okay, we've gone over the where, now let's talk about the how and the why. This is where we put it all together. This isn't just about knowing anatomy, it's about understanding the consequences of every move you make inside that joint. I want you to burn this into your brain. This is a direct cause and effect. If your portal is just a few millimeters off, if your angle of entry is too steep or too shallow, you will cause iatrogenic damage. The shaft of your instrument will pivot against the femoral condyle, scuffing up that beautiful, pristine articular cartilage. It is a 100% preventable complication.
And this image shows you exactly what's happening. Look at that top instrument. The angle is all wrong, so to get where it needs to go, it has to lever against the femur, creating that gouge in the cartilage. Now look at the bottom one. A well-placed portal gives it a clear, unimpeded path. That is the difference between a rough, damaging surgery and an elegant, tissue-sparing one.
Okay, let's bring this all into the real world. You've got a patient on the table, classic story. MRI confirms a symptomatic posterior horn medial meniscal tear. What's your portal strategy? How do you plan this out?
Here's how a strategic approach looks. You start with your anterolateral for a good look around. Then, under direct vision, you create your anteromedial with the spinal needle for your probe and instruments. But here's the key. To really see and work on the back of that tear, you need to establish that posteromedial portal. That gives you direct line of sight and the perfect angle for your repair devices. You're using the right portal for the right job, not just trying to make do.
And really, that's what this all boils down to. Anybody can memorize the anatomical locations. But mastery? Mastery is about surgical intent. It's about looking at the MRI, visualizing the entire procedure, and knowing exactly why you're placing each portal and how it's going to help you achieve your goal.
So, as we wrap up, I'll leave you with this one question to take into your next OR day. What's the one small adjustment you can make? Is it spending an extra 30 seconds on your pre-op mapping? Is it finally committing to using a spinal needle every single time for that medial portal? Whatever it is, that constant desire to refine this core skill, that's what truly makes a great surgeon.